Good afternoon and welcome to Policy and Blockchain Update, a webinar tweet chat combo from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in your browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. You can also use the Q&A panel to send in your questions as they occur to you, and we'll take them later in the program. And you can download the deck using the URL on your screen, and it has been sent out in the chat box. Just so you see how we're going to spend our time today, we're going to go approximately 45 minutes. First, we're going to hear from our featured speaker, Dr. John Halamka, CIO at Beth Israel Deaconess Health System, and then we're going to have our Q&A. So without any further delay, I'm going to turn it over to our good friend, Dr. John Halamka. Dr. Halamka, thanks for joining us.
Well, thank you, and Anthony, what a year it's been. I mean, here we're ending 2018, just a couple of days to go, and think of everything that we've experienced. So Athena Health was sold for $5.7 billion, and all the senior management is gone. CVS Health and Aetna merged for $69 billion. 23andMe got a $300 million investment from GlaxoSmithKline. Practice Fusion sold for scrap value to Allscripts. I mean, these are just a few of the things that have happened in the last couple of months. And then if you look at a very high level, and of course we're going to go into policies from ONC and CMS and just generally. But what did we see? We saw the FDA starting to have to deal with artificial intelligence and machine learning apps and frameworks, and we had the increasing notion of doctors prescribing digital apps to patients, and the FDA trying to figure out from a risk perspective what should be allowed and not. Because remember, in the history of the FDA, Bill Maisel, a former Beth Israel Deaconess cardiologist who oversaw a lot of the mobile app regulation writing, said, it's a risk-based framework. What's the likelihood if we tell Anthony, eat fewer carbs and run every morning, that Anthony will be harmed? Pretty small. What if we tell Kate, hey, you have an appointment next week, go? Pretty small. But what if we have an app that looks at your skin color and says, you look pale today, it's probably cancer? Well, that's going to be a pretty high risk, potentially nasty consequence kind of thing. And therefore, the FDA said, we'll regulate that stuff. But then here's the question. Should the FDA regulate to the same degree of rigor an app that it would, say, a pacemaker? Right? Something that was implanted in your body, and if by any chance there was a failure, it'd immediately die. Well, so what happened, Anthony, kind of interesting, and not yet in my slides because it's so quick, but just 5 days ago, the FDA issued some reflection on its experience thus far with apps. You know what it said? It said, actually, on the whole, these apps offer more benefit than risk. So maybe we should actually reduce the burden even on apps that are related to diagnosis and treatment, and not necessarily hold them to the same rigor that we would an implantable device like a pacemaker. So there you go. We've got massive change in the industry, the FDA rethinking what is truly risky versus benefit. And then other things that, of course, we've seen in 2018 is Amazon's joint venture with J.P. Morgan and Berkshire Hathaway. And, I'm sure, Anthony, your readers talk about what that is, and it's a little hard to figure out, I'll be honest. But if I were to guess, based on the fact that the headquarters of that joint venture is 50 feet from my office, I don't have any inside information, that it is about reducing employer health care costs. And asking the question, how do you change reimbursement, align incentives, what is the role of technology to ultimately reduce the total employer costs of healthcare? That's my guess. And, of course, you had Amazon buying PillPack And so Amazon now potentially getting into truly a healthcare transactional business. And everyone is talking open APIs. In my slides in a second, we'll get to a little bit about some of these technologies, but Apple putting the Argonaut Fire API in every iOS 11.4 and above phone in the world. That's kind of interesting. Your phone now has a healthcare API and about 500 hospitals connected to it. And sort of finally, as I do with this sort of environmental scan, the fact that Google just reorganized all healthcare. And you remember that Geisinger's David Feinberg left Geisinger to oversee all of Google's health initiatives, and that includes Google Brain and DeepMind and a lot of other stuff, though it does not include Verily. Verily, remember, is kind of a separate company in the Alphabet constellation. It's off doing really moonshot kinds of things. Though of interest in 2018, it did kill its glucose monitoring contact lens project. And if somebody would have asked me, I would have told them at the very beginning, don't do it, because your lacrimal glucose isn't related to your blood glucose. So even if your contact lens could sense the glucose, who cares? Not valuable. But be that as it may. Okay, so let's go ahead and go into our next slides. And here, let's make sure, yes, I have control. So let's talk about ONC. And so I talked to my colleagues at ONC, and the ONC folks, they obviously can't talk about notices of proposed rulemaking that aren't yet issued. But my guess would be that we're going to see in early 2019 the information blocking rule and other things that ONC will advise to ensure that data is more liquid than it has been in the past, and that there are appropriate administrative sanctions if an organization refuses to share data. So that'd be very interesting to watch. And the reason I say that it'll be interesting to watch, and this is about, Anthony, this is speculation, right? Because I can't know what isn't yet issued. But imagine this. So I am the CIO of Beth Israel Deaconess Healthcare System, 22,000 employees, New England-based. A 2-doctor practice in Texas asks for interoperability. Now, it's not that I would say no. It would be that what is the priority in my list of 200 projects that are all resource-starved to focus on a 2-doctor practice in Texas? The answer is, it's probably not so high. So I will look forward to what we might see in a rule, because will it allow you a sense of triage, right? If you're blocking thousands of bits of patient information from coordinating care in your community, I say bring in OIG and sanction those people. But if it's just, some transaction from some distant request that is not really impactful to your community, I don't know that that's information blocking, as it is just sort of logical business sense. So what we do know from ONC, and this is what's happened in the last quarter since our last call. So what they've done is part of the 21st Century Cures Act, now 2 years old. It's kind of hard to believe we've had 2 years since then. But ONC did release a report that looks at the burdens that are caused by healthcare IT. And what do I mean by burdens? Well, it turned out when I ran the Standards Committee, every single thing we did was well-intended, right? We weren't mean-spirited people. We asked the FDA or the CDC or CMS, what is going to be a very good thing for society? And if the FDA said document implantable devices, we said, well, that's good, because if a battery goes south, you want to be able to recall all those devices knowing where they have been implanted. Or if there's an outbreak, you want to know who has vaccines, who's had immunizations. Or if you want to measure quality and pay for value, you better have the data in the EHR so you can pay for value. Problem, unfortunately, Anthony, is doing all of those goals required every doctor at every visit to enter 140 pieces of information while making eye contact, being empathetic, and never committing malpractice. It turned out to be impossible. So what ONC has done is, they've put out a series of RFIs, and they've asked for the feedback on what might we think about reducing the burden of healthcare IT. Can there be regulatory relief? Can we relax the quality measures or the number of quality measures? So I've included the link to their site, and you can take a look at the areas in which they are focusing. But they really are asking, how do we get more bang for the buck, reduce the clinician burden, re-engage our doctors and nurses, and give them more time to see patients as opposed to just enter data. So, I think that's actually a good thing. You always have to be very careful because we don't talk about politics on this webinar. But sometimes actually deregulation is okay. And you can go too far, like environmental deregulation may not be okay. But if we've done too much to burden doctors, it's probably reasonable to take a step back. So ONC has done that. Similarly, Office of Civil Rights with ONC has done a request for information on HIPAA. Now, I am a pretty healthy guy, so I haven't had so many of these kinds of interactions. But how many patients have come to me and said, well, I went to medical records in XYZ hospital, and they said they couldn't give me my own data because of HIPAA? As opposed to, of course, what is actually a HIPAA requirement that the patient be given their own data. Or a doctor says to another doctor, I can't send you this patient record of a patient we share in common because of HIPAA. So, right, it's really very clear that there's this total misunderstanding of what HIPAA is, what HIPAA enables, what HIPAA restricts. So this is why the Office of Civil Rights is thinking it probably needs an update to HIPAA. And especially that's going to be true in our app-enabled world where there's more fluidity of data and different ways of delivering it. I mean, one good thing OCR did last August, was they issued the following guidance. If a doctor or hospital sends data to a patient and that patient maybe gets it on their iPhone, if the patient decides to tweet it, share it with a third party, donate it to science, the doctor and the hospital are totally held harmless. So this is sort of one thing to think through. OCR will be issuing some new guidance, no doubt. But if in the meantime, any time you send data to the patient and then the patient does something with it, there will never be a covered entity prosecuted for a breach because it's up to the patient what they do with it. And I think you'll see as we go to 2019, more and more of this patient-mediated data exchange kind of model, because it's just much more, from a privacy and regulatory standpoint, simple. And finally, really interesting, the VA has embraced this idea of open data access through APIs. And again, I've given you the link to this, but take a look. You as a developer or a patient or another doctor can create easy mechanisms by which you can get things like full medical records, scheduling information, claims information about a VA patient. So you sort of love this, that the VA is creating an ecosystem for innovation that doesn't depend upon the EHR or doesn't depend on VA staff doing this themselves, because with appropriate privacy and security roles, appropriate certification of the entities who can access that data, entrepreneurs can create really value-added systems for veterans. So something to certainly continue to watch. So that's what ONC has told me. Less burden, clarity on HIPAA, let's get data flowing better through APIs, and coming soon, the information blocking rule, but don't know what it says. Okay, and now let's talk about CMS. So Seema Verma recently, about 2 weeks ago, had a West Wing conference with Jared, and a couple of other folks spoke about where they see the future of healthcare IT. Now, of course, we could debate on this webinar, and that would be fun. Is Jared's involvement a blessing or curse? But hey, that's a topic for another webinar. And so what did Seema say? And I've included some links to her remarks. In effect, she's saying interoperability is a focus of CMS. And if you actually look where the power in healthcare IT is in the U.S. government at the moment, right, CMS is where the money is. So if Seema Verma is focusing on various types of interoperability, and potentially you might see reimbursement models changed because of Seema Verma policies, that's potent. And what are some of the things that she has said? Well, I'm going to cover things at a high level and then go into some granular detail. So she announced this idea of the My Healthy Data Initiative. And it's, again, getting more and more to this notion of patients getting access to their full data sets through APIs. And that will take many forms. But one of those forms is the so-called Blue Button 2.0. And that is an API that will enable Medicare beneficiaries to connect their claims data from Medicare to secure applications and services. Could be an app on their phone, could be a cloud-hosted service that takes your claims and then it gives you an analysis. You know, here's what you should do to stay healthier or something like that. It has 4 years of Medicare Part A, Part B, and Part D data for 53 million people. That's not bad, right? One API with all the claims for 53 million people. And that's Blue Button 2.0, part of this constellation of My Healthy Data. Other areas that I've heard Seema and others in CMS talk about is some interesting potential APIs around pre-auth, especially around medications. So let me give you actually, Anthony, a real example. I'll be in India doing some work with the Gates Foundation in 2 weeks. And it turns out the place that I'm going to be stationed in India has a very significant infectious disease problem. And I visited my primary caregiver who gave me a set of boosters of various immunizations, but then said, because you're going to this particular region of India, you better carry Godzilla-cillin with you. That's, by the way, not the real name of the drug, but you get my drift.
I was wondering. Yeah.
And I said, oh, my God, how much is Godzilla-cillin? And he said, how do I know? And, oh, well, we can go to a website, goodrx.com. Oh, look, it's around $200 for this prescription of Godzilla-cillin. I said, well, okay, well, goodrx.com, that's sort of great. It's got a list of what it thinks the retail price of a drug is. But what did it cost me? It's like, I don't know. I mean, you've got Harvard Pilgrim, you know, and you've got a special plan. Who knows? So what Seema and CMS would like to see, and I think this is a great idea, is if we had some APIs that were available, a level of maturity so that every patient and doctor could have a conversation, and it's like, oh, you have 2 or 3 different drugs you could take, and here is the cost and benefit of each of those drugs, which would you like? And then we can all make informed decisions instead of just showing up at a pharmacy and being told, oh, you owe a copay of $200, you know, and you sticker shock. And by the way, just for fun, my cost for Godzilla-cillin was $55. But who knew? and I did buy it, and I will carry it with me, because if you're in a rural Indian setting and you are you have a very significant infectious disease, obviously that's going to be a pretty impactful thing on your ability to function. So, but hopefully I won't need to take it. So there you go. It's claims download, Blue Button. You've got pre-auth. And then, you know, a fair amount of discussion at CMS in not only our claims data, but the rich clinical data that is gathered in clinician offices and hospitals, and transferring that to the patient. And I'm seeing this trend more and more, but we have to be careful. Because I think it's incredibly empowering to patients and families to get full access to their data, including their notes. We know that not everyone is going to have the technological literacy or the language skills or even the economic wherewithal to get the devices that are needed and the bandwidth required to connect to this stuff. And an example that I'll give you that will just illustrate this point. A very large tech company, I won't tell you which one, asked me if I would take some of their engineers to one of our Medicaid clinics. And this Medicaid clinic serves the homeless, the unemployed, those who have fallen through a social safety net. And the engineers just wanted to see how they might build new solutions for this population. So these engineers, average age 28, go up to a homeless gentleman and say, "What's your favorite wearable?"
Oh, no.
And the guy says, "Socks."
Yep. Mm-hmm.
Right? And so be careful. I love these patient and family engagement models, but we have to recognize that we have to be very sensitive to inequity. We have to be very sensitive to those who will have a have and have-not digital experience, and make sure that we in no way disenfranchise any of our population with some of these patient-facing digital access opportunities. So that's what Seema had to say. And then just, I guess, one other point to make on CMS. You probably didn't see this, Anthony, because it's a little bit obscure, but the Support Act, bipartisan support, was passed, and it is the Opioid Crisis Response Bill. Why do I even mention it on this webinar? Well, it turns out there's a huge telemedicine section in the Support Act. And what it emphasizes is as a country, we're going to address the opioid crisis and things like helping people through opioid withdrawal or reduce their dependency on opioids. In effect, just like people who are withdrawing from alcohol, certain medications, people withdrawing from opioids may be given certain medications, but it may be hard for them to access those medications, so maybe we need a telemedicine capability to help with that. So it actually outlines and encourages the U.S. to push more and more telemedicine virtual visits as a way of reaching more people, especially in rural areas, at lower cost. And I think that's it was CMS signaling that. I saw in 2018 almost a sea change in the way that telemedicine is no longer considered fringe. Telemedicine is considered an essential ingredient if we're going to reduce our total medical expense and improve quality and safety across the country by matching scarce resources, specialists and the like, to patients who need their services with not traditional, you must come to my physical office kind of approaches. And you saw a CPT code introduced to fund telemedicine, and more, it seems to me, there are emerging reimbursement models, especially in a value-based purchasing world, so that telemedicine is now considered mainstream. So we'll start seeing a lot of new products and services, I think, in 2019, taking advantage of this trend. So that's ONC and CMS. Now, what about other countries? Just want to take a quick moment to look at what I see happening outside the U.S. Because sometimes it's really important to take lessons learned from across the world. China has just begun a bold initiative to unify electronic health records for population health and machine learning, knowing that you can only train an AI system if you have curated good data to train it. And so part of this initiative will be developing a common Chinese data set so that each hospital and each office at each encounter will include problems in meds and allergies and labs and RADs, but also in China, acupuncture, botanicals, traditional Chinese medicine data, and that will go into a curated database, and we'll look at the patients of the past to inform patient care in the future. The pilot is going to be Chongming Island, which is just to the east of Shanghai. I'll be involved in some of that, Anthony, doing some of the design. Mm-hmm. And here's what's amazing about China. They asked me if I could do a tiny pilot in the first quarter of 2019. And we'll just start with 1 million patients, because after all, it's a tiny pilot. And that's the scale of China. And so imagine if we were able to achieve the entire medical experience of 1 billion people in a curated database, how that could inform the diagnosis and treatment of disease throughout the world. So it'd be very interesting to watch where that goes. Japan, in its super aging society, is seeing a huge urgency to get more mobile apps, more Internet of Things in home care, because there's no way you can care for a super aging society with a low birth rate and few primary care doctors without the use of more telemedicine technologies. So in 2019, it's actually going to have to change regulatory frameworks to enable more and more of that data to flow over the Internet, because it doesn't use the Internet for healthcare data right now, thinking it's a swamp of malfeasance and thieves, and well, the Internet is a swamp, that is true, but there are ways to use it securely. Let me quickly highlight some interesting things from the Nordic countries. You're seeing Norway, Sweden, Finland doing some interesting things with data aggregation and sharing for the benefit of society. Finland passed a law that says every citizen of Finland must, without an opt-out, share their lifetime medical experience for the benefit of society. The data about all health care they receive in their lives will be aggregated, anonymized, of course, right? No privacy issues here. But you can't say no. And their logic is this. If society is keeping you healthy, how would you deprive society of the benefit of your experience? Try getting that done in the United States. We can't even agree on, sharing immunizations across 50 states, let alone lifetime medical records. The work in India will be, in theory, leveraging Aadhaar, and that is the universal identifier that India has created that is biometric, so that a patient would walk in, simply do a fingerprint or eye scan, and then the medical records about that patient would be synthesized, would be put in front of the clinician and the patient to ensure a high-quality visit. And the one thing, of course, in the U.S. we still struggle with is this notion of a national patient identifier or a nationwide patient matching strategy, and India has already done that. Still controversial, but worth watching. And, of course, we've already gone through what I'm seeing in the Americas, but let me go through what I think from a technological standpoint we're going to see in 2019. More and more companies offering cloud services such as cloud-hosted decision support that connects to existent incumbent EHRs like Epic and Cerner and Meditech, Athena, eClinicalWorks. I am seeing the evolution of new startups saying we're going to, behind the scenes, get data from your EHR and then help you at the point of care, giving you precise information about the patient in front of you to help guide your decision making. And we have implemented at Beth Israel Deaconess one such system that helps us with the opioid crisis, and really helps us understand not only the drugs a patient has had in the past and the contracts maybe they have around the use of opioids, but what is the physician behavior across all the other physicians they are seeing, and how do we ensure that we're giving this patient the most optimal care. And that's all a cloud-hosted service completely behind the scenes of the EHR. We're also going to see an amazing amount of machine learning. And machine learning, again, cloud-hosted services, taking data and then coming up with what is going to be an insightful analysis of the data about the person in front of you based on the patients like this person in the past. It's going to help a lot with workflow. Where should this patient go next? How much OR time do they need? Do they need an ICU bed or not? Are they safe at home or not? And so we've got about a dozen of these projects. But one thing I'd highlight, if you're moving more and more to the cloud to host your data, to provide services, more and more to machine learning, we're going to have to be a little careful about privacy, right? Because go pick up the New York Times today. I'm sure you've already read the article, Anthony, which says, oh, gee, it looks like Facebook was actually monetizing all your personal data to lots of people without your consent. That data is the new commodity. It's the new oil. and so I think what we're going to also see is maybe potentially different statements about regulation on how data is used and for what purpose, but I'm going to actually expect we're going to see more and more startups creating security services, both to keep that data physically secure, but also to ensure that your policies and agreements are in place so that when you share data with a third party, you are really confident they're using that in a way that's appropriate for your policies and the patient's desires. So just, I didn't put it in my list, but cloud services and machine learning need to be complemented by new privacy and security controls. More and more Internet of Things. I'm sure probably you have a dozen things or more in your home, Anthony, that are monitoring stuff. Whether it's your Nest thermostat, your whiffing scale, your electronic thermometer, right? And so more and more of this data will be used to keep us healthy. Problem, of course, is we don't quite know how to deal with it, what to trust, how to interpret it, when to take action. So I think there are going to be some startups coming up with provenance. This is a bathroom scale with a fair degree of precision. So when it says Anthony, gained 10 pounds this weekend and he has congestive heart failure, it's probably that he ate 5 bags of Doritos, and therefore we need Lasix on board now. We will trust the data. As opposed to if you just have, something like a Fitbit and it says your heart rate's varying, well, I don't know, do we trust that or not? Because you're running and you're sweating and the Fitbit's not picking up so well. So more and more figuring out how to turn data into wisdom. I already went through more and more telemedicine and telecare. Going to be increasingly important to reduce total medical expense and improve safety, and it will be everything from real-time video chat to store and forward. Here's a picture of my mole. Is it cancer or not? Potentially this telemedicine telecare could be complemented with some machine learning augmentation. And then, of course, Anthony, you wanted me to talk about blockchain for a couple minutes. And so blockchain, I think, in 2018 has gone from the peak of inflated expectations through the trough of disillusionment as everyone lost their shirts if they invested in cryptocurrency. And now we're seeing it rise again to the plateau of productivity, where we're starting to see use cases that make sense, such as the United Healthcare, Optum, and Humana effort to put credentialing data for every clinician on the chain, or several startups looking at consent management on the chain, or various applications of blockchain to ensure data integrity. Data has not been altered, is not incomplete. So with blockchain, I think 2019, we'll start to see some real products and services that leverage the strengths of blockchain, get beyond the hype, and some new variations of blockchain, like Hyperledger, that give us better transactional speed without the environmental burden of consuming so much energy like so many of the other blockchain initial implementations required. So there you go, Anthony. That's sort of where I think we are as we end 2018 from a policy technology perspective across the world. And I'll just conclude by saying I'm incredibly optimistic about 2019. I actually think we'll see the convergence of academia, industry, and government in a positive way, and we'll see some real breakthroughs. So turn it back to you.
Very good. Very good. Great presentation. A lot covered, a lot to think about. So now we have time for some Q&A. So go ahead and send your questions in the Q&A box and leave the default set to all panelists, and we will take a look at those. So the first question that's come in is about TEFCA. Thoughts on TEFCA 2.0, its release date, impact on health information exchanges, which are creating interoperability, at least the 67 Strategic Information Exchange Collaborative SHIHIC. Members are exchanging alerts and CCDAs, question mark?
Sure. So here's always a fascinating question, which is, in the Obama administration, what we said is we looked at the healthcare IT policies of the previous couple of years, and we had kind of a market failure. That is, doctors and hospitals weren't adopting electronic health records at the clip we expected, nor were they sharing data. That, even though there were solutions out there, there wasn't a motivation to use them. So what we said is regulation is the answer. And it's fine. So you create a meaningful use and high-tech and ARA, and you got stimulus, and then you got adoption. The question is, as we look at the marketplace going into 2019, is regulation, the Trusted Exchange Framework and Common Agreement, what we need to do? Or will the market itself solve this problem for us, specifically referring to care equality and commonwealth? And why do I say that? You know, it's been a long time coming, and of course care equality and commonwealth have been in a startup mode for a couple of years. But I'm starting to see unbelievable adoption, such that you're getting EPIC, Care Everywhere, connected with care equality policies to commonwealth indexes, and Cerner and EPIC are exchanging data today. And as I talk to my fellow CIOs across the country, either they have connected to Commonwealth or are planning to connect to Commonwealth in the next year, and using a lot of the governance that we've seen out of care equality. So I know it's circuitous answers the question, but I just have to wonder if TEFCA as a government-based approach is actually going to be superseded by the industry solving this set of problems itself, and you'll just see wide-scale adoption of care equality and commonwealth. That might be what happens in 2019.
All right, very good. Next question. I like the optimism. Can you talk a bit more about the use of blockchain in the consent management process?
Well, absolutely. So how do we record consent today? It's recorded typically either on a piece of paper that's signed with a wet signature and scanned as a PDF, or maybe it's recorded in some kind of electronic form in an individual institution's EHR. That's unfortunately not very useful, because what if Anthony's in New Jersey? New Jersey, right? Am I correct?
Yes, yes.
Okay. Well, it turns out New Jersey has a set of consent and privacy laws that are different from Massachusetts consent and privacy laws. So what if, for some reason, Anthony wants me to help him with a consultation? What do I do? What kind of consent do I look to? Because we've got all these various aspects of consent under different regulatory frameworks, state laws, recorded in all these different places. What if instead what we said is, here's a series of questions. Do you agree to share, we'll just make this up, medications, problems, allergies, and labs and RADs with a care provider for your benefit? Yes. Then we'll ask an HIV question, right, because that's often a different statutory set of requirements. Then we'll ask mental health, substance abuse, right, because we know there's 42 CFR Part 2. There's all these various federal and state regulations in various classes of medical data. And if we just simply record the answer to about 5 questions in the blockchain, and then each time we want to share data about Anthony, we reference his most current set of answers to those questions, we can ensure his privacy preferences are respected. And that's a whole lot easier than a bunch of paper, faxes, PDFs, or isolated consents stored in EHRs. And so that would be the approach. Again, several startups thinking through that kind of approach.
Okay, very good. Can you say a little more about the payer credentialing blockchain item, near-term actions for providers?
Sure. So at Optum and Humana and United are working on following. Right now, I mean, this is actually unfortunately true. You know, Anthony, I'm an emergency physician. Mm-hmm. There are over 1,000 insurance companies in the United States. I need to submit some really basic information to all 1,000 insurance companies. Where did I go to medical school? Is it credentialed, you know, as a legit medical school, or is it a mail order university somewhere? Do I have a board certification from my residency? Do I have a current DEA license? Have I ever been arrested? You know, all this stuff. Well, again, same sort of question is, what if you had one trusted place? I mean, blockchain being a highly distributed ledger, but in a sense, each insurance company could look to the blockchain and say, aha, it turns out the DEA writes to the blockchain every time a physician has a valid DEA. So there's no question that John has a valid DEA.
Right.
Or he graduated from a valid medical school, or is board certified. And instead of having me filling out a 35-page application packet 1,000 times, right, you suddenly now have these sources of truth in the chain, and then they are trusted by all the insurance companies, and credentialing becomes infinitely less expensive and burdensome for payer and provider. So watch that. A guy named Michael Jacobs is the project lead. He's with Optum. For this particular activity, and it's all using the blockchain where blockchain is appropriate, right? It isn't blockchain for blockchain's sake. They're very realistic about where you need a trusted third-party public ledger to ensure the transactional data will flow.
Very good. What are your thoughts on banning faxing of PHI? What is the alternative?
Death to fax! Right, so I hear the issue, right? So let me just tell you two quick stories. Some years ago, as an emergency physician, at some hospital somewhere, see, I want to be very vague here, I saw some public servant, an elected official, and in that elected official's diagnosis potentially was the use of substances that weren't considered good. And that chart was faxed, and unfortunately, who knew that the fax number of the doctor's office was changed because of an area code split, and the fax number was a newspaper.
Oh, boy.
Oops! So this actually happened to me. This was 20 years ago, right? So point being, the challenge with this is that you might be sending PHI. You don't really know where it's going or who's looking at it. Oh, it's sitting on this machine with 100 people walking by it. So it's not the greatest. But furthermore, the thing about fax that I don't like is it's digital paper. You can't use digital paper for machine learning, analytics, or decision support, right? So if, let's say, hey, Anthony, you have an allergy to penicillin. I'm making this up. But we faxed your allergy to penicillin to another doctor's office. Well, how are they going to get that as structured data in an electronic health record so they don't give you penicillin, right? It doesn't help them. So fax is bad for so many reasons, but yes, to the question, the most common piece of technology in doctors' offices in 2018 is a fax machine. And what you would hope is, as we were talking about, Commonwealth, care equality, the use of direct messaging with CCDA, the ability to not only send a summary of care, but incorporate a summary of care. And all of this is part of the Promoting Interoperability Program, the successor to Meaningful Use. In effect, that gives you structured data going from clinician to clinician, not digitized paper. And that's where we need to go. But it's hard. I was just in Australia a few weeks ago, and there were some leading politicians telling us how wonderful fax workflow had been for them. And I, of course, looked at them and said, huh? So there's a lot of change and urgency to change, embarrassment because of mistakes that we need to highlight to get us off of fax machines and on to direct CCDA, Commonwealth, and care equality.
Very good. What do you think about Amazon's potential to be a disruptive influence in healthcare using cloud services and leveraging its Prime customer base? There are rumors of a launch of a Prime Health service.
And, of course, just, again, for the disclosure to the group, I know nothing about any particular Amazon plan. But I look to Amazon, and I'm feeling optimistic for a couple of reasons. So today, I have moved 11 petabytes of patient-identified data to the Amazon cloud under a business associate agreement. And while it is hosted in AWS, I can connect third-party services to it with much more flexibility than I've ever had in the past, because often these third-party services are also running on the Amazon platform. So on that side of things, the hosting, the interoperability, the machine learning, and the innovation, I think the Amazon platforms or Google Cloud Platform or Azure are really good places to store patient data with appropriate security and legal agreements. As to really the question was, do I think Amazon is going to leverage the, hey, let's make something up. People like you who had this disease also had that disease and used this product. Because that's, of course, what Amazon has done for all other aspects of our lives, so to speak. I haven't heard anything to that effect. I obviously think there's a whole lot of policy that we have to think through because that's going to be pretty controversial. If suddenly, Anthony, you log in and you're getting, you just bought a movie and now you're getting an advertisement for glucose strips. Mm-hmm. I don't know about you, but I would find that disconcerting.
Mm-hmm. Yep, a little creepy.
So great infrastructure, huge potential for accelerating the industry, but more policy work that would have to be done so that we would, as patients, decide that service is value-added and expressly permit it. We don't want one of these sort of Facebook-esque like situations where our data was used without our knowledge.
We talked a little bit before we started the call today about compliance, and obviously, during the call you talked about possibly the government trying to reduce some of the compliance complexity so physicians can spend more time with patients. And you had addressed this before on a previous call when you were involved with making policy and regulations that. Sometimes there are multiple entities layering policy requirements on the same group of people, let's say physicians, that are not totally aware of each of the implications of those other entities, and that as a cumulative, in and of itself, you look at what you're doing and you say, not so bad, but there's a cumulative effect that you may not be aware of. There's also the concept of unintended consequences that no matter how much you analyze and no matter how positive the change you're trying to make is, you can't see all the downstream effects. So just from a policy point of view, talk about that dynamic, the desire of policymakers when they're putting in issues that people are going to have to deal with to figure out all the downstream effects, but it's almost impossible. The more complex it is, the more other influence there are. You cannot see everything. Thus, you're in a position to try and walk things back and reduction. But again, even in reduction, sometimes you cannot see all the effects of the reduction to see if perhaps you're undoing some of the good things you've done. So take that wherever you want.
Oh, my God. What a complicated question. So let's think of the Obama era's perfect storm. You will do meaningful use. While you were doing ICD-10, while you were implementing the Affordable Care Act, and while you were implementing the HIPAA omnibus rule. And so meaningful use says share more data with more people for more purposes, but the HIPAA omnibus rule says, but you never better spill a bite. Mm-hmm. And, oh, by the way, it has to be completely recoded in a new vocabulary you have no idea to use. But don't commit fraud and abuse because then, so you see the problem, right? It became utterly overwhelming to have all these things hit simultaneously. So I think the lesson learned after being involved in regulation for 2 presidential administrations, I'm very, very reluctant to use regulation as a significant behavioral changer or incentive. I wherever possible, fine, we could set some general guardrails or policy outcomes, but let's try to let the doctors and the nurses and the companies that provide these services work together to achieve an outcome. Because I worry, especially that if a government sets a technology direction, it will put in concrete an obsolete technology. Right. And here's an analogy for you. In the Obama administration, when we did the meaningful use certification work, it would be as if we said, you must buy a CD player. It is purple with a green button. But wait, I want an iPad. Oh, well, we haven't heard of that yet. Right. As opposed to play music, however you want. So be very careful with the blunt instrument of regulation for all the reasons you've said, the unintended consequences. Let customers push the solutions and just set some guardrails, outcomes, or limits just to ensure that we get to where we want to get to.
Very good. Excellent. Excellent. Well, I think that is about all we had time for today. As usual, not only informative, but lots of fun. Wish I could join you on some of your travels, Dr. Halamka, but it sounds like I need to get a lot of shots, so maybe we'll skip that for now.
There you go.
When you close out your WebEx window, you'll be taken to a post-event survey. Please answer that if you have a moment. If you have the Chime CIO certification, let Chime know. You get a CEU for joining. When you receive, you'll receive an email of a link to the archive recording of this event when that's ready for you. And if you'd like us to produce a webinar on the topic of your choice, you could reach out to Nancy Wilcox from our team. And you can go ahead and view our webinars page to see our upcoming schedule. So with that, I want to thank our good friend Dr. Halamka for always doing these. They're extremely valuable and, like I said, lots of fun. And I want to thank you, our attendees, for coming to our webinars. So with that, everybody have a wonderful day. Thank you.
Thank you.